All right, folks, I'm going to start getting us started. Hopefully, our presenters will be here soon. But if you are here today, you are at our July Infant and Early Childhood Mental Health Office Hours. We've been doing this for a while now. These started as monthly meetings as we implemented mental health assessment for young children policies, and then transitioned to quarterly. And we're excited this year to be updating even a little bit more to have provider spotlights on different topics. And so we're going to jump in for today. Uh, we have a quick snapshot of our agenda. We're going to do a quick welcome and getting to know one another. I just put the prompt in the chat if you want to get started ahead of time. We're going to do a little bit of background and context setting just for folks who might be new to this space or aren't aware of some of the things that have been happening around our infant and early childhood mental health policies. And then we'll have some time to connect with some of our providers that we have joining us to talk about some of the shifts that they've needed to make at their agencies to support mental health assessments for young children. And hopefully, we'll have some open floor time for questions and comments throughout. Typically, we do infant early childhood mental health updates, and our update this time is just that we're doing this provider spotlight. So, in the future, there might be updates other than that. We encourage you to go to our website if you want to look at past slides that have updates and things like that. All right. So, welcome from Kiki and I. We are the small but mighty infant and early childhood mental health team here at the Healthcare Authority. I should note, though, we are supported by a whole bunch of people whose work focuses more broadly in the agency. So, our team is more than just us, even though we're the two that hold the primary work around this specific topic. My name is Christine Cole. I use she, her pronouns. My background is in primarily community mental health and some infant mental health consultation and program development. And I have the privilege of working with Kiki here at HCA, and I'll let her introduce herself.
Hi, everybody. My name is Kiki. I also work at the Healthcare Authority in our Division of Behavioral Health and Recovery. My title is the Infant and Early Childhood Mental Health Analyst, and I come from a background in program evaluation and technical assistance. So I am a data nerd, all things numbers, words, and really excited to be part of our team.
And we often do this in the chat box. If you wouldn't mind just sharing who you are and what you're hoping to get from today, that would be really helpful for us to be making sure that we save time for what you're hoping to learn. And we can also bring that up to our presenters. And so would love to know a little bit about who's here with us today, if you don't mind. If it's more comfortable for you, you are more than welcome to come off chat, but we usually do it through the chat function. Kiki, are you good with me to keep going?
I'm good.
All right. So while folks introduce themselves and what you're hoping to get from today, I'm going to give us a little bit of background. Some of you are going to be like, we've heard you talk about this a million times, Christine, and I totally understand. But for folks who haven't heard about mental health assessment for young children, we lovingly call it MHAYC. This is in response to legislation that happened a couple of years ago. I think it was 2021 now, Kiki. Does that sound right? Oh my goodness. So during ledge session in 2021, there was a bill that directed the Healthcare Authority to update our Apple Health Medicaid policies to align with infant and early childhood mental health best practices. If you go on our website, there's a whole beautiful diagram that talks about the history of that legislation, which was really informed by folks in the infant mental health community, identifying issues or challenges and barriers to how our policies don't fit when you work with young children. This policy has three main components. Two are about reimbursement. The first one is about instead of only having one mental health assessment with a young child, you're able to now have up to five. That doesn't mean you're required to do that many. It's just to say this little, circle over here around all the components that you might be trying to gather to give you more time for observation and engaging with caregivers to gather information and that sort of thing. It also included allowing for the healthcare authority to pay for travel to home and community settings, recognizing that children in this age range in particular are best served in natural environments, so home, community, maybe childcare settings. And then the last part of it was around requiring the use of the DC 0 to 5. The biggest question we get around this is whether, like, are we auditing this? Like, what's the oversight? And we have interpreted this piece to be about building our workforce's capacity. So there's no current way that we're checking on you, but there are resources available in the state for you to get training and other professional development supports for you and your team to be able to use this developmentally appropriate tool for understanding children's mental health needs in our state. So we've been implementing this since 2021. I would say broadly it's going smoothly. And then we also wanted to make sure that we're continuously improving and building off from this work. And so we went around the state last year to do an infant and early childhood mental health statewide tour, building off from the mental health assessment for young children, but we also dived a little bit deeper into other infant and early childhood mental health topics. The reason there's so many logos here is that we are super grateful for all of the partners who helped us to host this event and who shared their perspectives and to make sure that this was an event that was reflective of the needs of the community and that we all were able to come together and network as well. We did 10 listening sessions. We had a lot of folks attend and a lot of quotes. And one of the biggest things that we heard, which is the impetus of today, is that folks said we need more opportunities to connect with each other. Like, it was great to share with healthcare authority what's going on for us and what we need, but it was actually equally, if not more beneficial to have time with other providers to say, like, wait, how are you doing that? Or could you share that with me? Or did you know about this resource in our community? And so we heard you all and we want to do that. And so we have providers that are coming specifically to speak on topics, but we also recognize that those of you in this room might also have wisdom to share or resources to pass along. And so while we have a panel ready for you, we hope you all will also share your insights and ideas with the group. I think I have two more slides and then I'll get to hand it over to our panelists. We heard from folks that these are the kind of big themes that came out around what folks need when they're offering mental health assessment for young children. Folks really talked about that the process, the training, the different ways that you're going about it are really important, but they also talked about, like, how do we document this and what needs to go in our record? And so a lot of the topics that you'll see for our spotlights are centering around these themes that we heard, in hopes that will help to kind of share insights and build capacity in being able to do these different components. So the last piece is you are here today, July. We will be hearing today about agency shifts around culture changes, workflow, staffing, electronic health records, all those exciting things. We hope you'll join us in October and January, where we have two sessions about different ways of gathering information. And then in the spring, we'll talk about home and community settings. And so with that, we are ready to transition into our spotlights. I hope our participants are here, and we are happy to get started. Sally and Katja, I'm going to stop sharing my screen. And if you all wouldn't mind introducing yourselves, and just sharing with folks a little bit about, why your agency got interested in birth to 5, and whether or not it's just you that's infant mental health at your agency or if it's a whole team. And I will be quiet now.
Sure, I'll start. My name is Katja Ehrman. I manage the infant and early childhood mental health services at Ryther, which is a community mental health agency in North Seattle. We serve birth to 24 in a huge variety of programs, from general outpatient up through partial hospitalization. We have clinicians in detention facilities and all over, with working with youth care and other agencies that work with houseless youth, all sorts of things. We have always seen sort of some, at least 3 to 5. We have a long history with PCIT. And when the opportunity came up through the county to train in CPP and in PFR, so we took that and ran with it. And so we now have a team of 5 clinicians, including myself, who are doing that work. Most of us, we don't have quite enough referrals to be doing only the infant mental health piece, but we're all specially trained to do that and take whoever we get. And are hoping to grow that program and hire more clinicians at some point. I think it was important to me personally because I have always worked with young children and families, and I think that intervening early, as we all know, right, is more effective, and they're so freaking cute, and I really enjoy working with them. So that I think, I was very lucky that my upper management, when I said, "Hey, we really need to like do this and really do it well," that they really supported us in growing that.
All right. So my name is Sally McDaniel, and I apologize. I'm on vacation. I'm in PTO. I'm in California, so I'm on a phone because something happened with the link. I was on a different link. I was on a Teams link. I don't know if anyone else did that same thing too. Somehow missed that there was a Zoom one. So sorry if I'm a little bit late. But pretty much the same thing, but on the south end. We have been working with the young children for as long as I've been with the agency and prior, when the opportunity became available for this additional training and a more specialized intake process, we jumped on it and developed a team that had interest working with the younger population and to really specialize. We send them to as much training as we can, starting with the 0 to 5 training to understand the DC 0 to 5 and PCIT. We have a couple play therapists. We have a team right now we have 2 separate teams. We're affiliated with the Children's Specialty Care with Marybridge. So we have a team there as well. Most of those children in that facility have developmental differences, but then they also have a subspecialty of just the 0 to 5 population. And then we have it at Greater Lakes. We have a team of about 5 or 6 as well. We do have 2 staff that do intakes only, and then they assign to somebody else. And then we have 4 others that do their own intakes and then maintain the clients. One of our intake specialists does all the virtual ones because there are some families that want to do some virtual work, at least for the intake or the intake process. So that she specializes in that. And then the face-to-face, we have somebody obviously on site that does that. I guess we'll get into the other questions afterwards. So I don't want to jump into too much, but that's all I have.
Thanks, Sally. Yeah, you did a good job talking about kind of your intake team and specialty team. Is there anything else you want to dive deeper into that before I talk to Katja a little bit about workflow?
I don't think so.
Okay, cool. Katja, how about you share a little bit with the group around your what you thought about for your staffing model and workflows?
Yeah. So when clients come to us, they can like fill out a form through the website and get directed to do that right away so that we have some background information. When our scheduling department discovers that we have a birth to 5 kiddo, they target those intakes for our team. We do our own intake. Occasionally, someone will do an intake and be like, wow, this person is really better for this modality. And I don't do that. So we'll transfer amongst ourselves. But for the most part, we end up doing the intake and then following the family through until they're done.
Thanks, Katja. And good news, we have an intake coordinator here who's trying to learn from both of you today and what you did with your teams. Sally, I know you've talked to Katja and I before about, before MHAYC, everyone kind of saw everyone, and then you eventually, or when you first did it, then you transitioned to having an intake person. Do you want to talk a little bit about the thoughts around how it was working initially and the change to your workflow?
Yes, initially we had the identified staff. We sent them to the training, and then they did the intakes and kept the clients. For our Greater Lakes location, that was initially 0 to 5. We found that a lot of the 5-year-olds, at least from our model there, were not following through with all of the intakes. And a lot of that had to do with they were school age and they were coming from we have a lot of partnerships with the schools, and we see kids in the schools in elementary school, and they were making referrals, but they wanted them seen at school, and they just weren't really invested in the intake process. So we've had to adjust that to the 0 to 4 age group for one location. For the specialty care, they go ahead and complete them 0 to 5. We've also had to tailor our phone screeners and our assessor in our first sessions, really, for families to understand that this is a longer intake process. We found a lot of families either initially lose an interest or just not understanding why they can't start treatment now. So we've had to tailor our phone screeners to state your child is this age. This means we're going to do this type of intake process, and we're going to go ahead and schedule the first 2 appointments now. At that first session, the assessor will decide if you need more after that, how long it will take to complete. So that was kind of a learning process as well. And then once again, we do that in the first session under, explaining this new, House bill and why we're doing what we do and the importance of this. And part of that is also because a lot of them have multiple siblings and have been through the intake process, and it's a one and done, and then they start seeing their therapist. So they just didn't quite understand.
Yeah, that's really helpful, Sally, to share about kind of that helping folks to kind of know what to expect early on before the process started, so folks didn't had clarity around why it was different. Katja, I know your team had some challenges too around, identifying these kiddos and when they needed to go to a specialty team. I wonder if there's any lessons around that you wanted to share with the group.
I think it's just been we've had a lot of turnover in our scheduling or intake team, and so getting people to recognize, oh wait, birth to 5 is different, right? They have to go to the clinicians that do this work. They can't just go to anybody. Has been an iterative process of getting them to remember that. But it's been, now that they've kind of figured it out and gotten that going, it's gone much more smoothly. It's interesting you say, Sally, that you've had to really explain to families. I think for us, it's the change has been more just that we're doing what we did before, but we're getting paid for it differently, and we have the space to make the diagnosis without having to rush, which has been really lovely. We do a mix of Medicaid and commercial insurance, and I'm really finding when I do the commercial intakes, I'm like, I feel really pressured with the diagnosis. So it's really nice to have that time, and I wish the commercial insurance companies would get on board with this also.
Only we had invited our insurance friends here today so that they could hear your ask. Thank you both for sharing about workflows. I know we also talked a little bit about training and retention and your approaches to internal and external training. I wonder if, like, Katja, you want to start with kind of your guys' model, and then we pass it over to Sally to add what they're doing too.
Yeah, we have for the last couple of years, I think we've really been relying pretty heavily on the grants that we've been getting for CPP, for PFR. We have an in-house trainer for PCIT. And I think that I have started to really, as we've grown, develop that to be more internal. I am training as a PFR trainer, and hoping we do some informal training. We're also have been doing the DC 0 to 5, availing ourselves of those free trainings, hoping those will continue. But I have also developed sort of an internal, so like as people get started and we're waiting for the official training, we can at least get them up to speed on those. So I've been developing a lot of that material. And it's hard because community mental health, we do have a lot of turnover. And so I feel like, especially with the CPP training, which is 18 months long, right? So by the time we get through the cohort, people are starting to leave, and then we get through the next cohort. So keeping everybody trained has been one of the biggest challenges, I think, particularly since we're such a small team to start with. It's not like there's lots of people who can take those clients.
Yeah, I see lots of head nods, Katja. Sally, do you want to add? I know you all have overview internal slides too. So are there other things that your team is thinking about and doing for training and retention?
Turnover is a thing. I mean, the original team that we started with, I think we have 2 of those remaining. Well, maybe we have, yeah, it's been about a half. So as soon as we get somebody trained and specialize in it, then, something they leave, and then the people that are left are kind of flooded with the littles, and then everyone else, and we'll get to this at the end, but, I guess some of the downfall is that, it's hard working with littles. There's a lot more people in the room and there's a lot more parent work, and some of the newer staff maybe aren't as comfortable with that. So there was a little bit of a relief when people were willing to take on the littles. Now they can focus on this. So if we have to shift a little bit and somebody leaves, it's like, okay, well, there's whoever was seeing this 4-year-old is now left. You can get a 4-year-old. It's like, wait, I don't do the littles. It's like, okay, well, the intake's done. A lot of work has been done. You used to take littles, or you're in child and family. You can now take littles. I'll help you and support you. So to help make um, to ease the minds of staff, we have included the 0 to 5 consultations in our staff meetings, so that a portion of it is reserved for anybody working with the littles, can present the case, the work that they're doing, get input from the staff. So they can kind of see, I can do this. Oh, I have input to stay regarding this as well. So if I got one, then I can manage it.
We also have a weekly drop-in consult for people working with the littles.
Yeah.
Katja, can you say a little bit more about that, around how that's staffed and how frequent that is and how folks participate?
Yeah, it's weekly. There's just a Teams link where people can come join me in my office, and then I'm available. And then they bring their cases, training cases, or other cases that they're dealing with. I mean, again, it's all pretty much my same team. But if people are interested in learning more about working with the littles, or have even like a 6-year-old, and they're kind of doing the similar work, they can come in and consult about that with us.
Sally and Katja, this is not on our run of show, so you can say, no way, Jose. I'm wondering for both of you, like you're talking about offering support for staff. How did you build your support or your capacity to offer that to your teams? Or what were the ways that your agencies has had staff, like supervision capacity to support infant early childhood mental health?
Just kind of made it happen. Yeah. Just it's a need. It's important. I think staff have a idea of what they want to specialize in, whether it's co-occurring, whether it's working with teens, whether it's DBT, whether it's LGBTQ. And there was enough of an interest for staff that this is their passion. So just feeding off of their passion really excited the team in general, that we have these specialties, and that, we have something to offer. And I'm the go-to person. And I think it really builds, their sense of belonging on the team. So.
I think for me, I mean, our senior director is our PCI trainer, so she has a lot of support for us, and we have a lot of will, but maybe not as much knowledge. I rely really heavily on my team, including Susanna, who is here in the call, who is amazing. I'm really lucky. My staff is excellent and really skilled, and come with a lot of really interesting backgrounds in child welfare and education, and so we pool our skills. Like I'm officially the manager, but I think we work very collaboratively and very we rely a lot on each other's sources of information, and I'm just as likely to bring a client to consult, I think, as they are. So it's we manage.
I love that. I love that. I feel like every time I talk to anyone who has an infant early childhood mental health like specialty program, it's the two options you all said. You either had a leader who said we're going to do this, or you had staff that said like this is like something we need to do. Like I need you to figure it out and help me make this happen. And I feel like, CPP, child parent psychotherapy isms of trusting the process is what I hear both of you talking about, of like kind of voyaging in and learning as you go. So I really appreciate you both highlighting that for everybody. And a less exciting topic, but I think also equally important, is around thinking about the electronic health record. Like, how did that need to be updated or changed? Any sort of billing challenges? I know those are like the less fun topics for us all maybe to think about in the clinical world. But Sally, I'm wondering if we could start with you, and then Katja, if you wouldn't mind adding in around some of the things that you've had to work out, the kinks around billing or records.
Yeah, it was a little bit of a learning curve with some of the beginning billing, because they weren't quite sure how to utilize all sessions. For instance, after our first session, if they were in daycare or if they were in a preschool and we wanted to connect with that preschool teacher, we received our ROI to give them a call to get input, and maybe had a 15-minute conversation. There were some mistakes with the billing of case management, and in between that we had to learn to how to navigate around that versus is that considered one of the intake appointments? Is that a case management? So that was a little that part was a little challenging. Um, the we collaborated with Navos and Haruko, who already had an early infant mental health, and we developed we have a system called Epic, and we developed some smart phrases that we pulled in. So though we had to kind of fine tune those to figure out if we want the tables to pull in from some of the axes, if we want to really structure. So we really worked on structuring sessions 1 through 4, and to develop smart phrases to pull in the information we needed so that we can all pull that into the assessment at the end. The assessment, there were some challenges with the assessment on our part as well, because in Epic, you can't start an assessment and then go back and add a little more to the same assessment. You have to put it all in at the same time. So there was a lot of copying and pasting, and the whole process was a lot of work after. It's not like doing a regular assessment, trying to figure out those pieces. If they were to enable Epic to pull in data from each appointment, it would pull stuff in from years back. There isn't a workaround that they have figured out. So we had to develop a Word doc basically of our assessment, and they fill that in, and then they have to pull that back into the end one. So there is quite a bit of cut and paste. Some of the sites do things a little differently. And it's all the info's there, and we're not honestly uniform. I would say the MBH site, Greater Lakes, and Navos have some differences in some of all the information gets there, but whether or not their notes look the same in the first 4 sessions, it's a tad bit different in how that's pulled in.
We use Credible. And I think from the clinician standpoint, it has actually gone fairly smoothly. But when I was prepping for this and I asked our billing and database people, they were like, oh, we're doing that manually on the back end. So they have created entries for us where we can put each session in that we do for the assessment. And they are manually doing something on the back end to bill it. And I was like, oh, I did not realize that was happening. So it's been fairly smooth. I think we continue to tweak, right? We're adding assessments in to Credible so that they are all electronic. We have just been doing them on paper and scanning them in. So we're hoping to get all of those in as we have discovered sort of which ones we're using the most. We are working on just streamlining the processes and figuring out as we go sort of, okay, this isn't working. How can we do this a little differently? But it's actually, I think, been fairly smooth. I have to say, I really appreciate our CPP supervisor calls because we meet regularly and people are asking questions and we're talking about some of this stuff. And so that has been a really nice way to connect to other people doing the work. And I also get Haruko's wisdom often, which is great. That's been really helpful for us in terms of, for me, coming into this as a newer manager, as developing this program kind of from scratch, what do we need? And then kind of working off, okay, what's our current policy? How do we need to tweak that for the little ones? How then do we integrate this stuff about the multi assessments sessions and all of that? But I think we're getting paid, so
that's a part of it.
Happy.
Getting paid is an important piece of the puzzle for sure. I know you've mentioned CPP a couple of times, Katja. So before I transition to the next question, I'm wondering if you have anything to share with the group about how you all got involved with CPP and because you keep mentioning the grant, is there anything that you can share with this group so that they know where to go to learn more?
This is actually how our infant mental health program started. It's kind of funny. I was actually partially at Ryther and partially in private practice. And in my private practice, I was getting emails from the Barnard Center and they said, hey, we're looking for people to do the CPP training. And I was like, hey, this is great. And so I brought it to the directors at Ryther and said, this is not something for my private practice, but I wonder if Ryther would want to do it. And they said, yes, do you want to manage it? And I said, yeah, I do. And so that kind of grew into, okay, now we're finding other things. So some of them, I think most of them have come from my senior leadership. Otherwise, in terms of hey, we have this opportunity. Would this fit into sort of the vision for what we've got going here? and have been sort of picking what we need. And then, yeah.
Thanks, Kasia. Sally, you all have done some trainings too, correct? Where did you all access your evidence-based trainings, or are providers doing that independently?
Um, mostly independently. Yeah, I mean, we send them to 0 to 5, and we have in-house PCIT, and we had somebody that did their own play therapy. So yeah, and we do mostly in-house based on who we have available.
Yeah, thanks, Sally. I was trying to remember what it was. And that's something we heard on the statewide tour too from folks is it's hard to access some of these professional development opportunities and hard to know where they are. So I appreciate you sharing a little bit, Katja, too. Um, Folks just that are listening, we are almost to our open kind of Q&A time. So if you have questions, feel free to be getting those ready. But for Katja and Sally, we had just kind of thought about ending on reflections around implementation, around like surprising challenges or unintended consequences or, the biggest lessons learned. And so wondering if each of you want to share a little bit about those pieces.
For us, it was really just a heightened awareness. I mean, before we would get them, but we would never talk about it. So now that we have the specialty team, we've developed this improved way of completing the assessments. It's been important to share with the entire department. So therefore, just understanding the 5 axes and how important the parts of it are, and the modalities. I mean, we really speak to, I mean, I shared our slide presentation that we onboard staff with. I think it increased just communication and collaboration amongst the staff and comfort with working with the younger population, but just an overall heightened awareness of how to work with younger children. And like Katja said earlier, it may be a 6-year-old, it may be a 7-year-old with some developmental delays that you're treating like, 4 or 5-year-old. That the same modalities still apply.
I think for us, the biggest challenge at this point is like the initial sort of like, oh my gosh, what are we doing? Let's get these trained up in these modalities. Let's figure this out. Is now, how do we be intentional about growing the program? And how do we develop additional referral sources? How, yeah, thinking about onboarding new staff. Okay, like what additional training do we need? How do we structure that? And just sort of making sure that we're growing at a sustainable pace and trying to think about the things we hadn't thought about before because we were just trying to get our feet under us. We also started all of this during the pandemic, right? I was in the CPP Learning Collaborative that started in December of 19. So we were also learning how to do this virtually, which was a whole other mess. But yeah, so I think it's just becoming, how do we grow? How do we refer? How do we market? That's sort of our next big challenge.
I have one more, something I thought of what you said about the growing. One of the ways we grew is we developed a partnership with one of the local Tacoma School District, and we have a behavioral health consultant in all of the ECAP and Head Start programs. So we have worked over the past 2-3 years, really working on a stream of how to first do an observation for a student in a classroom, and then the next step would be to make a potential referral. We follow up those referrals differently. We report back to the school whether or not they followed through, and we honestly get most of our referrals through them, to the point where like we're ready for summer because there's too many referrals coming in. So
I'm curious, Sally, how you get
wonderful.
paid for that. Does the school district pay for it? Are you doing that like as a way to get those referrals, and so you're not charging for it?
For the consultant part?
Yeah.
Yeah, I have grants with them. They have to, part of their programs with the CAP and Head Start are a grant that pays for that to occur. And they have, we have to have 2 observations per year, 2 for one program, 3 for the other. So they already had asked us that. This just came shortly thereafter, and it was a perfect combination since that's that age category. So, and that helped us grow and really just define that language and the partnership for the community. And it's been wonderful to have a resource for the school districts and a partner that they trust to be able to, serve them.
That makes me think of one of the other bigger challenges for us. We'd love to move into more home visiting. We are pretty much exclusively office based at this point, but finding the support from our leadership for that, because of the financial pieces of that, has been difficult.
Sally, how did you build that relationship with Head Start and ECAP? Like, where did that originate? Did you outreach them? Did they outreach you?
Um, well, that's a long story because for the longest time, we were out of the Tacoma Public Schools because there was a deal with another agency using the 1/10 of 1% that they were kind of locked in with that agency. So we were hands off. We had a therapist at our site that also had her ESA. She has a master's in education, and her goal was to get back to the schools. She happened to leave and go to the Tacoma schools, and they didn't really have great mental health support, and said, how can we get a partnership? I say, hey, there's a hands-off thing. So she reached out to the director of Whole Child, who said that thing's ended. Let's meet, let's talk. We met and we talked, and then we put mental health clinicians in the schools. After that was so successful, our name was handed off to the ECAP Head Start, and then that partnership. So we have two separate contracts, actually, one for the Whole Child grant, we call it, and then the other's ECAP Head Start, and they're run by different people, but yeah, word of mouth, basically.
I love it, Sally. Thanks for sharing the story. That didn't seem like a very long story to me, but maybe others feel different. I see your question, Stephanie, and I promise I will get to it. I also see some of our other friends like Jillian and Tina and Cindy and Chris that are also leaders who have been thinking about this topic. And I'm wondering if any of you, as you heard Sally and Katja share about the shifts or about some of the things that have been surprising in implementing MHAYC, if any of you would be brave enough to come off mute and share anything from your agencies that you've also seen or that we maybe didn't touch on. Totally putting you in the hot seat unexpectedly, so you also can say, Christine, no way. I see you, Jillian.
I'll be brave. Yeah, I resonated with a lot of what was being said. I think in terms of the billing piece, I can relate to what you were saying, Katja, and credible backend stuff, like just trying to make it make sense within the system that we already have built, and the multi-assessments, kind of getting families on board to say, this is a process, and we still have areas to improve on, but I think in general, it's going pretty well. I'm trying to think, like, specifically, I think it's the billing piece and the sustainability of like the travel and home visiting and things like that. But I really love hearing from both of you and kind of how it's working, and also the electronic health record portion of that, because that just feels like a whole big task that isn't my area of expertise in terms of like the setting it up, more of like the clinical stuff. So yeah.
We are incredibly blessed to have a database person who is like amazing. So I can just be like, this is what I want. And she
Yes.
figures it out.
And we have that too. And it is like our agency assessment and how we can kind of take it, but also change it to fit that like specialty population. It's complex.
I think for us, integrating the 5 intake session was a really positive shift. We also had a lot of support as far as like our EHR from Lou Olson, who many of you guys know, who was acting more in a consultant role. I think for our clinician, what I've heard the most when we made that shift was how it allows for more flexibility, more creativity in the assessment process. I think most of our therapists had a really hard time really accurately assessing and giving a diagnosis after one session, and a lack of confidence. And I think that has been the biggest impact, feeling more confident around diagnosing very young children, feeling more confident about the diagnosis provided, having more flexibility and creativity in assessment. We've been thinking a lot more about like which assessment tools are we using, how do we get that information, how can we ensure that the way we get the information is very family driven. And yeah, that led to additional training and additional assessment tools, which was really exciting. A lot of observation-based assessment tools that within one session we would never have the time for. So it allowed for a lot of, yeah, continued training, continued development, continued confidence and competence in our therapists, and also keeping families more in that driver's seat of the assessment and helping them understand better why and how we give diagnosis to very young children. I think that's something a lot of our therapists had run into, families not really fully understanding or feeling concerned about the young child having a diagnosis, and really keeping them in an active role in that assessment process. Right now, we're working kind of on an expansion and hoping to offer services to children 3 to 6, because that's what we have found is the biggest gap that we have encountered. It's something that our therapists have been very frustrated about when they try to refer our 3-year-olds when they age out of our program. And I'm curious what billing will look like as we expand our program. Yeah, that's the question I have right now, and something I look forward to discussing with our leadership, with our billing specialists. Yeah.
No pressure, Cindy or Chris. I just want to make sure neither of you wanted to add something because I saw you come off mute before I read out Stephanie's question.
Can I just throw in here? I go back to the 80s of the first wraparound programs and the first WISE programs. These children were institutionalized and in residential placement. We began seeing 4 and 5-year-olds at the onset of WISE and wraparound back then. I am so grateful for what you people are doing. We were not given the tools then when I treated 4-year-olds and 5-year-olds that we have now for this 0 to 5. And I understand not all of these children are WISE eligible. I understand that. But when we began treating the seriously emotionally disturbed children, we were using tools that were not child friendly. We didn't have the therapies that we're talking about here today. We used adult psychotropics. We used DSM, diagnostic categories. I have now spent almost a year with the Healthcare Authority. Thank you so much, Christine and Kiki, for aligning my thinking from that early childhood and wraparound work to our ability now to intervene in these children in a different mindset. Not all of these children I get are going to be attachment disorders and things that I saw in the DSM. But what we get to do is see an opportunity to influence the developmental and neurodevelopmental success of these children before they get to the DSM. And so I'm very curious about this unfolding in the state. By the way, I'm the behavioral health consultant for Wahkiakum County Health and Human Services. We do direct outpatient behavioral health there, and leading our clinicians into treating 3-year-olds, 4-year-olds, 5-year-olds, but not under a DSM, which is a whole different mindset and a whole different way to comfort parents, to bring parents into the behavioral health system when they have very serious concerns about a young child. So I've learned a lot in the last year or two about rethinking where I come from, about having an opportunity to address children before preschool, before children. And I'm very curious. We are seeing everything you guys are seeing. We are using a Word document for our assessment. We are out there in the community and in the home and assessing in multi-session. My curiosity of the next few years before I leave this profession will be, how can we sustain these children as they transform into the school system? It will be a different look at these children than I had coming out of a wraparound onset and how we identified children with serious emotional disorders 20 years, 30 years ago. So I'm very curious as to following this with our clinicians as to what can we promote in the developmental and neurodevelopmental success of these children that enhances their entry into the school system next. We did not have this when Wraparound and WISE was beginning. So there is some intersect, but there's a lot more here, you guys. And I just am very, very, having had struggled with these children at the earliest stages of deinstitutionalizing and bringing kids out of state facilities and wraparound, this is where we needed to be 30 years ago. And so grateful, so grateful. The state has brought this to us. It's national. 0 to 3 is bringing us to us, and our clinicians and clinical staff. We're not all trained in this. We're not. I was not trained in bringing out wise and wraparound children. I was trained in adults. But listening to you guys, we're all moving this system for children. And I'll end with saying there's only one comment I've always learned, and there's a Chinese proverb that says there's only one beautiful child, and every mother has it. And so we want every parent to come into my agency and make sure whatever their fear is, whatever their concern for their infant and the success of their child, we're right there with them. We're right for seeing this beautiful child. So I just wanted to share with you some of the history of where this has been and where you guys are speaking and addressing today.
I appreciate you, Chris. I think it's really easy for those of us that are much newer in the field to not always see how much growth has actually happened and that there was a lot before it that is changing. And, when you're in the midst of the changes, it doesn't always feel like things are different. And then you look back and you're like, oh my, it's very different. So we appreciate you.
I don't feel like I can follow that appropriately because I think you did that very beautifully, Chris. I have been encouraged today just to hear how different groups are implementing. We are still in the process, and I feel like it's been pretty slow. But in Yakima at Children's Village, we've been working on trying to have all of our clinicians trained. We had an infant mental health specialist for years and years. And when she retired, it left a big hole in our team. And so at that point, I'm like, this is silly. If we have one person that gets this, training, then the rest of the team is still in the same boat if that person leaves. And so we have kind of stretched ourselves to have all of our clinicians getting training. But it has taken a while to get going with implementing. We have been doing some work on trying to match up, like, okay, for the DC 0 to 5, what would that assessment report look like based on what we've got now? So you guys probably can't see it, but I have giant sticky notes on my wall because I've been trying to go through both and map out like what's missing from this one so that we're hitting all those requirements. So we're kind of still in that process, but we have been using a bit different mindset, which I think is really helpful. And we've done some multiple intake assessments, which is helpful. I feel like we're still looking for some better assessment tools for our itty bitties. And Sally, like you were saying, I love the idea of having maybe an intake specialist, and yet I feel like everybody needs to have that skill set. We have a very small team. So if everybody has the skill set and can do the assessment and then work with that very young child, I feel like we're broadening our ability to provide that service here. So we have some great resources. We have our ESIT team here on site, and we get to do a lot of collaborative work with them, which is really helpful. But I still have a few people that are like, oh my gosh, I can't do the littles. And I'm like, guess what? You're getting the next 2-year-old. So we're trying to share the love a little bit. But it's just really nice to be able to be a part of the communication and the conversation here. So thank you, everybody. I appreciate that.
Love that, Cindy. Love that. I feel like you gave a good platform to ask Stephanie's question in case anyone has the answer. I know some folks in here probably do. Stephanie had just asked about the requirements and where to get information about becoming an infant mental health specialist endorsement in Washington State. So does anyone here feel like they could answer that question?
The Washington Association for Infant Mental Health website has lots of good information about that. I'm working on it myself.
Nice. Thanks, Katja. Is there anything you could share, Katja, about that experience?
I haven't gotten too far into it, but they have a very clear list of like what they want you to do and what you need to document.
And Katja, what made you decide to pursue an endorsement? Because we don't require that as Apple Health Medicaid in the state. And so curious if you wouldn't mind sharing with folks what you're thinking or the benefit for you is.
Um, I mean, some of it is sort of like a marketing tool, right? That like, as the manager, I'm whatever, right? Credentialed. Some of it is my own personal professional development. But most of it is the sense that I will be into the community and be networking better.
Love that. Thanks, Katja. Anyone else here that's endorsed that or has gone through the process that wanted to share about the experience for Stephanie?
This is probably not helpful because I never went to the endorsement, and I'm not the specialist on my team regarding the endorsement. It's one of my colleagues, supervisors. But what I just wanted to bring in is the perspective of we have a lot of team members in our ESIT teams that are non-mental health therapists, our OTs, educators, PTs, speech therapists that have been very interested in the endorsement because it provides this um, the further education about social emotional skills and mental health that they wouldn't get in any other place, which has been really encouraging. And we have a lot of non-mental health therapists that are endorsed because it really widens their perspective and knowledge in regards to mental health.
Yeah, thanks, Tina. Not my HCA hat. I mean, technically it is in my job description, so I feel like it's not inappropriate to share with all of you, but I do have the endorsement. I went through the process not in Washington initially for the infant mental health specialist. And, I think what Katja was saying about my own like professional development, it gives like a kind of a framework to kind of think about like where are my skills and strengths and where could I give myself more like direction for building capacity. But also, I was really fortunate that I had an infant mental health endorsement coordinator, that the process itself was a very reflective process and thinking about infant mental health principles and like how do we, our own developmental progress and things like that. And so it was a very like experiential journey, not just about acquiring letters or a credential. Um, and so if that's helpful, Stephanie, I don't know if you have more questions for the group, but just a little bit of info.
I really appreciate that. No, actually, so yeah, I just became the Birth to Three manager here at Spark, and we have 7, hopefully soon to be 8 FRCs, and so we really want to get some, everybody PFR'd, and work together with Bridget Collins. I keep calling them and saying, "Hey, let's partner." I think that we are seeing a real need in Skagit for maternal health. And so, talk to our health nurses and, they are outnumbered. And so, this is a way for us to do it, but so I appreciate hearing how you are financially making it possible as well, because that, is unfortunately a reality for us. So yeah, anything that you have to share with me. I mean, my background is I was chemical dependency counselor and then went into childcare. and now I'm here, but did the whole process. And so it's just, lived the journey, experienced the journey, but would like to just have, probably an endorsement just to, make insurance companies happy. Anyway, but thank you guys for all this wonderful input. It's very helpful.
We're glad to hear that, Stephanie. I heard Cindy make an ask about screening tools, or at least comment that that's a need. And so I'm going to very unabashedly share that we will be talking more about screening in January. So we hope you will join us. And if any of you have information or things that you have to share, please feel free to reach out to Kiki and I, because we would love to make sure that that is like a well-rounded panel and also that folks are able to share. So please join us in January. We only have 2 minutes left. And so I just wanted to take a moment to just thank our panelists today. It's hard to believe that I met you both like 2.5 years ago now. And it's just really fun to have this time with both of you and appreciate you so kindly sharing your wisdoms and your experiences with this group. I think it's just so much more powerful when we get to hear from each other and the folks that are actually doing the work. It's a different level of understanding and appreciation for the complexities of this work. So thank you both so much for for coming today and sharing with us. We appreciate it. Kiki, partner in crime, is there anything you'd like to say as folks bid adieu?
Well, we hope to see you at the next office hour provider spotlight, which will be in October. I put the link in the chat to register for those upcoming sessions. We'll have a similar kind of space then. And as always, it's so wonderful to see all of you and just know that we're holding you in our hearts and our minds. We think about you and the work and the families and the kids every day. So you have supporters here at HCA, and we can't wait to keep learning from you. Bye, all.